Good afternoon and welcome to today's presentation, Cardiothoracic Surgery and the Horrible Complications. The information presented by the expert is not to be used as legal advice and does not indicate a working relationship with the expert. All materials obtained from this presentation are merely for educational purposes and should not be used in a court of law sans the expert's consent, i.e. a business relationship where she or he is hired for your particular case. In today's webinar, Dr. Mahan will discuss Society of Thoracic Surgeons Database, complications reported to the Adult Cardiac Surgery Database, complications reported to the General Thoracic Surgery Database, complications reported to the Congenital Heart Surgery Database, INTERMACS adverse events, and summary. To give you a little background about our presenter, Dr. Vicki Mahan is a board-certified thoracic surgeon. She is the Assistant Professor of Surgery and Chief of Pediatric Cardiovascular Surgery, as well as co-director of the Hospital Heart Center. Her expertise includes valve repair and aortic surgery, brain protection during hypothermic circulatory arrest, neonatal myocardial protection, fetal pacemakers, and cardiac transplant. In her free time, Dr. Mahan is a judo student, competitor, teacher, and mentor, as well as a coach and referee. Her main responsibility in judo is to grow people. In addition, she works with teenagers and young adults in defining their career and professional goals and has recommended multiple judo students for scholarships and college education. Attendees who require a password, the code for today is cardiothoracic. During the Q&A session, we ask that you enter this passcode into the Q&A widget for CLE reporting purposes. The Q&A is located to the left of your screen. Please remember that if you are applying for CLE credit, you must log onto your computer as yourself and stay for the full 120 minutes of this presentation. You are also required to complete the survey at the end of the program. Please note that CLE credit cannot be given to those watching together on a single computer. Tomorrow morning, we will send out an email with a link to the archive recording of the webinar. The slides can be downloaded from the resource list at the widget at the bottom of your screen. Thank you all for attending today, and Dr. Mahan, the presentation is now turned over to you.
Thank you. I'm going to start with two cases before I get into the STS database. The first case is a 5-month-old who presented with respiratory distress, had several episodes over the previous 5 months, required urgent intubation, and an echocardiogram showed dilatation of the left ventricle with mitral regurgitation. The coronary arteries could not be seen well on echocardiogram. A CT angiogram showed L kappa. The patient ultimately underwent emergency repair of L kappa. The next case is a mother who had poor prenatal care, and she had a spontaneous vaginal delivery with what was described as a normal newborn. The newborn was discharged to home, and the mother brought the child to the emergency room in extremis. Echocardiography showed hypoplastic left heart syndrome. Both of these cases had both of the children lived, but there were multiple morbidities associated with these different pathologies. When I talk to families, I tell them cardiothoracic surgery is not normal, and anything that can go wrong will go wrong. And the Society of Thoracic Surgeons database has tried to get a handle on morbidities and mortalities in order to help us improve as cardiothoracic surgeons. We now have 4 different databases, the Adult Cardiac Surgery Database, the General Thoracic Surgery Database, Congenital Heart Surgery Database, and what was recently added, the INTERMACS database. The database was established back in 1989, and we were looking to improve our quality and patient safety among cardiothoracic surgeons. The patient population is expanding. The patients are sicker. they're older or younger. We are now operating on very young newborns. As of January 1st, 2018, we have the 4 components as I've described, and the database has grown exponentially over the years, both in terms of participation and stature. It is now an international database and it involves most countries of the world. As a national health care leader in healthcare, transparency, and accountability, the STS believes that the public has a right to know the quality of surgical outcomes and has established the STS Public Reporting Initiative, which allows participants in the database to voluntarily report their surgical outcomes to the public on a website that is easily accessible. Public reporting is available for the Adult Cardiac Surgery Database, General Thoracic, and the Congenital Heart Surgery, and we're hoping that we'll be able to do the same with the INTERMACS. Before we go on, a lot of families ask about what the risks are of various different surgeries, what the morbidities are. There is an online STS risk calculator that's accessible by anyone through the internet. The problem is that it's only limited, in this case, to isolated bypass, isolated aortic valve replacements, isolated mitral valve replacement, AVR and CABG, MVR and CABG, mitral valve repair and CABG. We are trying to expand that. It is difficult since every single patient is different. But if you take a look at that risk calculator and you go down in terms of what's entered into that, you'll see there's a lot of factors that determine the risk of mortality, renal failure, permanent stroke, prolonged ventilation, infection, reoperation, morbidity or mortality, the length of hospital stay. We do not have this sort of thing for the pediatric side of the house. So if we now go to the complications reported to the Adult Cardiac Surgery database, you'll recognize very quickly that we are required to report pretty much anything and everything to the STS database. We also are required to report these to the Department of Surgery, M&Ms, which then go to the hierarchy within hospitals. So for example, sir, I've listed all of these. I've pulled these out of the database so that they are all inclusive. Surgical site infection within 30 days of the operation. And if you look at the sternal site, you want to know if it's superficial or if it's a deep sternal infection, i.e. mediastinitis, because morbidity and mortality is much higher in the latter. So this is a picture of a deep sternal infection, mediastinitis. Some of the cases are done through a thoracotomy. We're interested to know if there was an infection of the wound. Conduit harvest sites. Fortunately, with the new harvesting techniques, the infectious complications have dropped dramatically, but we still have conduit harvest site infections. Cannulation sites, generally through the groin or through the axillary artery, the subclavian artery, there are infections. And then they want to know if there was some sort of an intervention that was required for an identified wound infection. And these can just basically be incise and drain it and put a little packing. It may require something called a wound vac. It may be extensive, where you may require a muscle flap or an omental flap. The sternal bone may need to be resected. The picture on the left is what's called a wound vac, and this has really aided us in helping patients with complicated pathology. It used to be where we would have to pack these wounds and then debride them at the bedside or in the operating room. The wound vacs have really helped in terms of decreasing morbidity and mortality. Muscle flaps are shown on the right, and this is not all inclusive. We use the pectoralis major in the majority of the cases, but sometimes that's not available, and we have to use other muscles to cover the wound. Reoperations are not uncommon in adult cardiothoracic surgery for various reasons. Most of these patients have multiple medical problems, and many of them are on multiple medications. Many of them have diabetes. They require anticoagulation. We're constantly looking for these things. But the reality is that all of this increases the need for reoperation. So did we have to go back to the OR for bleeding? Tamponade basically means there's blood around the heart, compressing the heart, and decreasing the amount of blood that's getting to the body, and you have a low blood pressure. There may be problems with a valve, mechanical valve or a valve repair, where you have regurgitation or the valve's too tight, you're stenotic. You may have myocardial ischemia. The vessels that are bypassed during coronary artery bypass grafting, relatively speaking, are large blood vessels. They're not small blood vessels. And many of these patients, unfortunately, have a lot of small vessel pathology. And also one of the problems with doing coronary bypasses is you can thrombose or you can embolize distally later down the line. Reintervention for myocardial ischemia. It may be that there was a problem with one of the bypass grafts, or it may be that another vessel needs to be bypassed that you did not think you needed to bypass up front. When cardiac surgery started, everyone was bypassing everything identified on the angiogram, so you'd have people with 6, 7, 8 bypass grafts. We've now learned, if you look at the literature, that you don't need that many bypass grafts. There's a lot of collaterals. And sometimes someone needs a vessel grafted that you didn't think needed to be grafted. Aortic reintervention is not that common, but you can have dissection of the aorta. If an endovascular procedure is done and there's been a stent placed, it can slip. And there are other cardiac reasons that you may have to go in. That includes something embolized to the heart, or there's a hole in the atrial septum or the ventricular septum. Graft, there was tearing off of the graft. There's a multiple reasons for the need to go back. There are non-cardiac reasons, and many of these patients have other pathologies. It's not unusual for them to need something else done, especially the sicker patients. Things like a gallbladder, getting acute cholecystitis is not that unusual in this patient population. Open chest with planned delayed sternal closure. Sometimes we have to leave the chest open because the heart's too swollen. If we put it back in the chest at the time of the initial surgery, the heart will not beat properly, and we have low blood pressure. We have basically cardiogenic shock, and the patient wouldn't do well unless we leave the chest open and we diurese the patient and let the heart get smaller and everything get better. Sternotomy issue is quite common in especially the older women who have osteoporosis with diabetes. Their bone is osteoporotic, and the wires that we use can rip through. This is not uncommon. Sternal instability with the young man, it can be a big problem. Just in coughing, they can break through very heavy wires, and some of them will need to be rewired. Sepsis is something we do see. We do give antibiotics to these patients. It's generally directed. Infectious disease service generally has some sort of input into this. And sepsis doesn't necessarily have to be diagnosed by a positive blood culture. People think you need a positive blood culture to say you're septic. That is not true. Neurologic sequelae are very real. Postoperative stroke is very real. And if a patient has had a stroke prior to undergoing open heart surgery, they are at much higher risk of having another stroke. It's important to know, for us to know, if it's hemorrhagic or ischemic. Sometimes we're not able to determine that. That has to do with how we treat the patient. Transient ischemic attack is neurologic symptoms that occur for less than 24 hours. The outcomes are better than the documented strokes. Encephalopathy, from various reasons, are not uncommon. So we have people coming in, their family members coming in, and they say, Mom's not quite herself, or Dad doesn't sound like he knows what's going on. Encephalopathy due to anoxia or drugs or metabolic reason are not that uncommon in especially the older patient population with a lot of disease processes going on. A coma or an unresponsive state is not that usual, but it does occur. And many times you cannot figure out why it occurred. On the left, I've shown a hemorrhagic stroke is where you have something that has happened to the vessel where there's actually bleeding into the brain proper. With an ischemic stroke, usually there's something that is embolized to a vessel and has prevented blood flowing to the distal brain parenchyma. That embolus can be something like a clot or it can be air. And what a lot of people don't know is that people talk about, well, I've got hardening of the arteries in my aorta, in my coronaries, in my carotids. What they don't understand is you get hardening of the arteries in the smaller blood vessels in the brain as well. And just a little tiny clot or emboli of something can cause an ischemic stroke. Now, the neurologic deficits that we see are not just limited to the brain. We can get problems with the lower extremities. There are patients who require clamping of the aorta, and there's no blood flow. Put them on deep hypothermic circ arrest or something, and you can get lower extremity paralysis. You can get paresis, which is a weakening. Phrenic nerve injury was more common when we used ice slush. It is much more common in the pediatric population because of what dissections are required to address the different congenital heart processes. Recurrent laryngeal nerve injury is not that uncommon either. This is a nerve that supplies the vocal cords, and we think that it's more common than what is currently diagnosed. Most of the time, the phrenic nerve and recurrent laryngeal nerve injuries in the adult populations generally are not problematic and generally function will return. Pulmonary problems are seen very frequently. Many of the patients are smokers. They have chronic obstructive pulmonary disease, asthma. They've had pneumonias. And yes, vaping does increase the risk to this. Marijuana also does. And prolonged ventilation is something we try desperately to avoid. Pneumonia can be either bacterial or it can be viral. Thromboembolism, we try to get people, when I tell a patient that I'm going to get you extubated as soon as possible and I'm going to get you up and out of bed, walking around, they just kind of look at me. We want to get them in a safe situation where their lungs are working and where they have a lesser incidence of deep vein thrombophlebitis and pulmonary thromboembolism. Pleural effusions, that is fluid in the chest cavities around the lungs, are not that uncommon, particularly in mitral valve surgery. And most of them will resolve with diuresis in time, but sometimes they have to be drained and we have to put a tube in. Occasionally, we have to do a bit more than that. We may have to do what's called pleurodesis, but that's not that common. Pneumothorax is more common in individuals with underlying lung pathology, and some of them do require a placement of some sort of drainage tube. Some of them do quite well with just placing them on some oxygen. But there are some of the other complications of mechanical ventilation. There are complications related to intubation, and that includes, dental problems. It can include problems with the epiglottis, the mouth. It can include problems with the vocal cords. If a patient's been ventilated, had an ET tube in for a period of time, you can get what's called subglottic stenosis. That can be at various levels. Most of the time, nothing needs to be done about that, but it can be progressive, and it could require dilatation and possibly resection down the line. When you get into that category, everything's been tried before you go in and try to resect it. Ventilator-induced lung injury is not that uncommon. When you increase the pressures on the ventilators, the problem with patients who have undergone a surgery on the heart-lung machine is the lungs are very leaky, and you have a change in what's called compliance in the lungs, and because of that, you have to increase the pressures to properly ventilate, and the lungs may be sick to start with, and it's not unusual for a bleb to pop, a patient to have emphysema or COPD, or what you would term a weak lung, and have air around the lung, and that may need to be addressed, putting in a tube. Complications related to oxygen. There's such thing as too much oxygen. We know that. And what we try to do is decrease the oxygen as quickly as possible. So 100% oxygen, a patient may require that up front, but we're sitting there and saying, what's the most dangerous thing from the ventilator? What can we decrease in order to put the patient into a safer situation and not compromise the patient otherwise? And infectious complications are very well known from the ventilators. We do everything to prevent this. However, it is still a problem that we continue to deal with. Renal failure is not unusual, and if you have renal failure before surgery, you are more likely to have renal failure after surgery, and that does not necessarily mean that you need to undergo dialysis. It may mean we need to address the diuretics. It may mean we need to address electrolytes, but certainly we see it, and we see it commonly. Ultrafiltration in these patients, what that means is taking electrolytes out through some special catheters. Generally, we do ultrafilter patients on the heart-lung machine to help out, and we're not seeing that as much as we used to after we started ultrafiltration in the OR. This is just a diagram of what can happen in the operating room. You can get hemolysis, you can get hypoperfusion, you can get inflammation. There are a lot of things that can happen, and every one of them affect the kidneys, and you can get acute kidney injury because of this. There are criteria for renal failure. Usually a nephrologist, we have nephrologists see these patients, and they help us out in terms of adjusting medications, helping us decide when we need to dialyze or take fluid off. So most of them will resolve with a little bit of time. There are vascular complications. Iliofemoral dissection, when We're doing things like a TAVR, or we can cannulate the iliac vessels, the femoral vessels, and put people on heart-lung machines. Dissections are not uncommon. Most of these, we cannot do these on children, small children, because we just don't have the size of cannulas. And also, we can, with the adults, there's generally larger vessels that will supply the distal leg. But with the adults, they're being operated on usually for coronary disease. Atherosclerosis affects all the blood vessels, and that includes those in the groin. And so dissection, you are at risk for a dissection, and it may or may not need to be addressed. Acute limb ischemia, the problem with a lot of these patients, if it's not related to cannulation, but when we put the cross clamps on, there is atherosclerosis. You can have embolization at atheroma, or you can have a thrombus form if the perfusion pressure was lower. You can have something just kind of float distally, and which may be difficult to identify. Many of these patients may need mechanical assist device. There are complications related to this. This includes the intra-aortic balloon pump, ventricular assist devices, and there may be an insertion site issue. Most of these in the adult populations we put in through the groin. We try to stay away from the chest. Bleeding is very real. We have to anticoagulate these patients. Thrombotic and embolic complications likewise are real. Hemolytic, we don't see that as much anymore, but infection is a problem, and we try to get these out as quickly as possible. So if you look at the picture, the foot on the left has that leg is ischemic, and that needs to be addressed very quickly. In the adult populations, many of these folks have collateral circulation, and things will get better with time and with some anticoagulation. But there is a group of patients that will need to have intervention, usually by a vascular surgeon. And there are other mechanical assist device related complications that I'll talk about later on. Rhythm disturbances, and especially in the adult patients, is very, very common. And there's a high percentage of patients that require pacemakers. That's for basically a slow rhythm. ICDs are patients basically who've had ventricular tachycardia or fibrillation. We may need a combination of those as well, but these are things that are commonly placed, and they're commonly placed not only during the hospitalization when they underwent their heart surgery, but they are also followed by the cardiologist and may need them placed later on. Cardiac arrest, we do see this. The reason for it is many times not clear. And the majority of these people, the arrest happens in the intensive care unit. So people who are very used to this are right on the spot. And although a cardiac arrest is a serious adverse event, the patients who have one in the intensive care unit are more likely to survive just because of their location. The post-op aortic endoleak is referencing stenting from generally it's a dissection, usually in the descending aorta. Not that uncommon. There are different types. Most of the time they can be taken care of by putting another stent in, having an overlap. It's not usually a big issue. Aortic rupture, although rare, it is seen, and generally it is seen with patients who have some sort of aortic pathology, such as a Marfan syndrome, infected aorta, something along that line. So this is a patient who would need a permanent pacemaker. This is complete heart block, and the patient may do okay, may be talking with you, but you certainly don't want to send them home with something like this. Aortic dissection, this can be either antegrade or retrograde, many times associated with the cannulation site. These aortas are sick. They're not healthy aortas. We're talking about patients who are older with a lot of medical problems, diabetics, hypertension, hyperlipidemia. During the perfusion, there may be aortic side branch malperfusion that we have to identify. Be it to the problem is if there's malperfusion to the brain, that can be problematic, and there are things that we do to try to prevent that. We have something called NIRS, which we put on the patient's forehead. It's an end organ indicator of if blood is getting to the distal vessels. Aortic stent graft-induced entry tear. We're not seeing that as much anymore with the new equipment that has become available, but it's something we must be attentive to. Anticoagulation is required in a lot of these patients. And if you think about it, the cabbage patients, the patients with coronary pathology, they'll be put on aspirin. Many of them are on Plavix. And the valve patients, many of them end up on some sort of a anticoagulant like Coumadin. So the anticoagulant event is not that uncommon. And by what I mean an event, they could have blood in the urine, they could be coughing up blood. When they shave, they could bleed. So that's not that uncommon. Pericardiocentesis is generally required for fluid around the heart. If it's a bleed, usually it presents during the first few days of the operation, and many times those require going back to the OR. But many of these patients, they'll go home and they'll get fluid around the heart and will be slow in development. But they're just not feeling good. They do an echo and they said, oh, there's a lot of fluid. And usually what we do is the interventional cardiologist can, under fluoroscopy and echo guidance, drain these, put a little drainage tube in there. Usually we'll admit them to the hospital and see, make sure they do okay. This can recur, and it has to do with the different pressures, and you've got raw surfaces that are leaking, and generally it's not blood, it's generally basically plasma. Gastrointestinal event is not that unusual. The GI tracts go to sleep when you're on the heart-lung machine. Many of these patients have GI problems up front. We do give medications to prevent ulcerations, peptic ulcer disease, but we do have patients who have GI bleeds and have other problems that have to be addressed. Liver dysfunction is more common than what we used to believe. Full-blown failure, if a patient has a hepatic problem, say they have cirrhosis, needs open heart surgery, they're much more predisposed to having failure after the surgery. But liver dysfunction associated with cardiopulmonary bypass and coronary disease and aortic disease is more common than what we had thought, and it's something we watch for. Multi-system failure means basically that you have several organ systems that are failing. Usually it's the kidneys, the liver, and the lungs. We try not to get to that stage, but there are patients who do get to that stage, and the more organs that fail, the more likely you are not to make it. Atrial fibrillation is something we used to completely ignore. It's an irregular heartbeat. It originates in the atria. Your ventricle responds at different rates. We used to not think anything about it. What we now know is that the quantity and quality of life related to atrial fibrillation is less than if the patient is in sinus rhythm. What is now being done is there are multiple recommendations regarding should we do something to try to avoid this? Should we clip the left atrial appendage, where if you go into atrial fibrillation, you can get clot forming there, then it can kind of float to places in the systemic body, to include things like the brain, the kidneys, distally to the legs, things you don't want it to do. And if you can keep them in sinus rhythm with atrial fibrillation, they have to be anticoagulated, which you really don't want to do. And they do have problems from a long-term standpoint. It can actually put you in heart failure. And then there are other things that you can describe when you enter your data into the database. In the cardiopulmonary bypass and with the Vacs, things that we can identify are things like airlocks. We can have a false display of the pump output due to incorrect setting of tubing size. We have different sizes for different size patients. You can have arterial line rupture. You can have aortic cannula dislodgement. There can be drug errors, and there can be ABO incompatible blood transfusions, either in the operating room or outside of the operating room. Blood transfusion problems are still a problem despite everyone doing everything that they can to prevent this. Just because the patient leaves doesn't mean we do not follow them up with regards to data entry. We have got to know the status at 30 days after surgery, and we have to indicate how we ascertain what their status is. What is now being recommended is, like the pediatric population, this be taken out much longer than 30 days. We're actually very interested in what the outcomes are of these patients. The plan is to try to improve things so the patients have a quality as well as quantity of life. So let's move on to the general thoracic database. There are complications, although these patients generally do not go on the heart-lung machine. They still are at risk, and in particular, a lot of the surgeries required by these patients are in patients that are quite sick, things like COPD, who now have lung cancer, esophageal cancer. They may have some sort of a dissection. So they're quite sick usually. If there was a post-operative event, many of these are anticipated, but there are some that are unanticipated. If it's unanticipated post-operative, we want to know what the primary reason is for a procedure to take care of it. And some of these we're able to have interventional radiologists take care of it. We're able to put in glue for something like a bronchopleural fistula. There are different types of empyemas, which basically means there's pus around the lungs. The middle lobectomy for torsion, what happens with the middle lobe on the right side is it's smaller than the other two lobes, and it can flip over. And what can happen is you can have an acute situation where there's no blood flow going to that lung, and there's no drainage, and it can be quite emergent. The conduit necrosis failure following an esophageal surgery is very serious. Esophageal leaks are things that are looked for in all of these patients who require esophageal surgery. They're usually studied post-procedure at the proper time. Many of them just need to be made NPO. They may need a small drain, but there are patients who are going to require surgery down the line. Chylothorax basically means that there's chyle. With the surgeries that are done on these patients, The lymphatics are an approximation to many of these structures, especially the esophagus, and it's not unusual to get a chylothorax. The majority of these we don't need to operate on. Generally, we will drain them. We'll change their diet. Many of them will scar down. Fortunately, the interventional radiologists now have a technique where they can actually embolize some of these so that we don't have to go back in and operate. This is something you dread. This is a leak after an esophageal surgery, and you have to evaluate this very rapidly, and you have to decide what you need to do. You may not be able to make that decision until you're at the operating table. Pulmonary complications are very common, especially in the patients requiring surgery for a lung cancer. Generally, these patients have been smokers and their lungs are sick going into the operation. But if the air leak is present for greater than 5 days, when we do resections, we use different techniques to try to prevent air leaks. But if we're not successful, we may need to do something beyond that. Atelectasis means part of the lung has collapsed for whatever reason. Many of these patients secrete, have a lot of secretions, basically because of underlying lung pathology, and some of them may need to have bronchoscopy to open up a part of the lung, which is very important in these patients. Fluid around the lungs, not uncommon after many of these surgeries on the esophagus or on the lungs. Many of them don't need to be drained, but there are some that will require drainage, and some of them will require pleural abrasion or something else, resection of the pleural. Pneumonia is not that uncommon. Again, they are all treated given prophylactic antibiotics. That is not a cure-all. Acute respiratory distress syndrome, ARDS. These lungs, many of these patients, their lungs are not healthy going in, and we do have problems getting them off the ventilators in some cases. We do have different techniques to try to repair this, to try to prevent this, but we do see a good number of patients with ARDS and respiratory failure. Bronchopleural fistula basically means that if you've done an operation on the lungs, there's bronchus that you generally, it's how you breathe into the lungs, and sometimes there is an opening that hasn't closed, although generally these are closed in double layers, but the tissue is edematous or it just doesn't heal properly, so you can get a bronchopleural fistula. Pulmonary embolism, all of these patients are set up for pulmonary embolism, and all of them are prophylaxed for pulmonary emboli. Again, pneumothorax is not that uncommon in these patients. The ventilatory support, all of these patients, we are very much aware that the ventilator is not a good thing. It saves a lot of lives, but it has its own complications. So we try to get these patients extubated as soon as possible. And having said that, we don't want to reintubate them if at all possible. Tracheostomy is never a good thing. It has its own complications, but there are patients who will require tracheostomy for various reasons, and there can be other pulmonary events as well. So this is a pneumothorax that's going to require some sort of a drainage catheter. And from a cardiovascular standpoint, many of the patients with pulmonary problems have atrial arrhythmias, and we have now learned we need to treat those atrial arrhythmias, be it usually with medications. Most of these will resolve, but there are some patients where they have the arrhythmia for a prolonged period of time. Ventricular arrhythmias, They're not as common as the atrial. Many times are related to electrolyte abnormalities. Many of these patients, yes, they have esophageal disease, they have pulmonary disease, and oh, by the way, they also have heart disease. So they're followed closely, and generally cardiologists are involved in the care of many of these patients. Certainly the intensivists are involved in the care of these patients as well. Cardiac problems after these surgeries are less nowadays, but they do occur. It has to be thoroughly evaluated. The majority of the time they're deemed small infarcts and don't need something done emergently, but they are thoroughly evaluated to determine whether they need something done right then and there, or if it's something that you can just follow. Deep vein thrombophlebitis is something we prophylax against, but all of these patients are set up for DVT, and other cardiovascular events are not that common. This is an atrial arrhythmia where something really needs to be done, and this looks like an atrial fibrillation with a rapid ventricular response. GI problems, ileus, not uncommon, and many times related to fluid and electrolytes. Getting the patient up and out of bed, walking is the best thing you can do for ileus. An anastomotic leak requiring medical treatment only, i.e. antibiotics and nothing by mouth. We do see that. We follow those very closely, but it must be reported. The esophageal anastomosis, there's a high percentage of those. We don't know how the esophagus is going to heal. You do what's called wide anastomosis. These can stenose down, and they may need dilation later on, usually not in the during the initial hospitalization, but rather down the line. Conduit necrosis is something we don't see that much of, but when we see it, it has to be addressed emergently. And you can have what's called delayed conduit emptying requiring intervention. That has to do with the neural involvement of the anastomosis, and that can be problematic. Clostridium difficile infection, we don't see that commonly, and other GI events to include things like cholecystitis or liver failure. We do see it. Fortunately, they're not that common. This is something you don't want to see. The black, that's pretty much dead, and that's something that must be addressed fairly quickly. We try not to give blood products, but when we do, we have to report it. Urology, especially the males, these operations that I'm describing tend to be a bit longer. Foley's are placed. UTIs, we try to pull the Foley's as quick as we can to prevent UTIs, but we do see them. Urinary retention is not uncommon, where you pull the Foley, the prostate has gotten large, the bladder's not contracting well, and they may need catheterization until the strength of the bladder comes back. The individuals are getting up and walking around. This occurs in both males and females more than in the male population than the female population. There are patients we have to discharge with a Foley catheter, not common, but it does happen. And here are some of the mechanisms of urinary retention. We try to address this fairly quickly. Bladder infection can cause a systemic infection, and we try to address that very rapidly. Empyema is pus around the lung, and it comes in various flavors. It can be very liquidy, and we could drain that with a chest tube, put them on antibiotics. But you can have a situation where you have a large collection that's thick, that you cannot drain with a chest tube, and that will require some sort of a debridement. We also are required to report surgical site infections and sepsis and any other infection requiring IV antibiotics. This is a picture of an empyema that is requiring some sort of surgical debridement. With debridement and antibiotics, the post-op course is longer, but many of these patients do post-operatively. We do see strokes in these patients, and that has to be further defined as ischemic versus hemorrhagic. We do see recurrent laryngeal nerve paresis by unexpected. The recurrent laryngeal nerve is located by the lungs, and it's more commonly injured in lung surgery than it is in the regular adult cardiac surgery. So they put unexpected here. If it's something you're expecting and you have to sacrifice it because of the pathology, that's okay. They want to know if it's unexpected. Delirium's not uncommon. Many of these patients are on a lot of medications. They've undergone a big operations. They've had fluid and electrolyte shifts. They're out of their own environment. So that's not very, very uncommon. Other neurologic events are less common, and that includes things like paresis of different muscle groups. You can get a neuropathy. Depending on how you're positioned, you can have different neuropathies. Renal failure we do see in these patients, even though they haven't gone on the heart-lung machine in most cases. Cardiothorax requiring medical intervention, that means you don't give them anything by mouth. I put them on TPN, or you change them to a low-fat diet, and hopefully things will resolve without a surgical intervention. And other events requiring operating room with general anesthesia. And there's a lot of different things that would require, say you need to go back because the skin has come open over your wound and you have to reapproximate or something like that. The other thing is some of these patients are not initially, it depends on the pathology we're dealing with. Some of these patients don't need to go to the intensive care unit. If we are expecting it, we usually schedule a bed, but if all of a sudden they have to go to the ICU after they've been transferred to the floor, or you're in the operating room, you say, we're having a little bit more problem than we expected, we probably need an ICU bed, that has to be reported. In the thoracic patients, the status at 30 days after surgery, again, it has to be reported. We're trying to get that extended as well. So with that, I think we're at the question and answer stage.
Thank you. If all the attendees can enter in the passcode for today, which is cardiothoracic, and any questions that you may have. Just so you know, Dr. Mahan, I am sending the first question over to you.
Okay, thank you.
Mm-hmm.
That is a good question. The question is, how detailed a consent form do you recommend provided given the myriad of possible complications? When I sit down and talk to families, and I'm dealing right now, I'm a pediatric cardiac surgeon now, which in plain English, it means I do adults and pediatrics, and I've done a lot of thoracic. The patients, when you start talking about the pediatric population and children, we're not just talking about a few years, we're talking about a lot of years. So what I generally do, generally the nursing staff will sit down with them. Then I will sit down with them with the nursing staff, and then the nurse will then again sit down with them and discuss it. But the way I normally handle it is I will describe the procedure in detail as to what I have to do. Now, cardiothoracic surgeons are in a good position because fortunately our cardiologists and our pulmonologists are absolutely excellent at describing what needs to be done, and what to expect. So by the time they get to us, the families at least have some sort of a knowledge of some of the language that is being used. We also have a lot of books so we can show them pictures. But I sit down with them and I tell them about the procedure that we're doing, and I make sure they understand what the different options are. And usually that has been discussed by the cardiologist or the pulmonologist. And what a lot of people don't realize is these patients are presented in conferences. So it's not a one doctor decision that, oh, you need this. The different options have been discussed at length. And there's been basically a team decision as to what the best option is. But we certainly make sure the patients know the different options, and many patients opt for a second opinion. When I'm done describing everything, and some people are more educated than others, I take as much time as I need, and I sit down, and when I start talking about complications, the way I handle it is I say, this is a big procedure, and anything you can think of as bad has probably happened. The most common complications are these, and that doesn't mean other complications will not happen. The consent forms in different hospitals, and a lot of folks don't know this, are dictated by basically the hospitals. So the consent form that I use here at St. Christopher's is different than the one I used at Beth Israel. When we put a note in the chart, the way that I do it, and certainly we do not rush patients to sign the consent forms unless it's an emergency, and there are times where we have to take it out of their hands. But the majority of the time, it's more of an elective situation. And you give them time to think about it, and I always have the discussion, almost always with an RN with me who has a command of the language, and I always make sure that RN talks to them, and then I also look at the RN when I'm done with what I'm saying, and I look at them and I said, is there anything I have missed that I need to discuss? In the preoperative note that I put indications for and complications of whatever procedure I'm doing, to include but not limited to. And the things that I definitely put in that note are things like infection, bleeding, seizures, stroke, injury to surrounding organs, death, and bleeding. There's another one. But I generally dictate it, like, for example, if it's esophageal surgery, what you have to say, put in that note is, say, esophageal leak, stricture, that sort of thing. So you have to change what you put in the pre-op note relative to what you're talking to the patient about. I also tell the patients, with what I'm doing, and even in the adult population, is just because we're dealing with a problem right now, you need to be followed because this is a lifelong problem. And a lot of folks, with the pediatric, it's easier with them because when I sit down with the families, they understand this is a lifelong problem. The adults, it's more of a problem. Oh, you fixed my heart. No, you need to be followed, and you need to be followed closely by your cardiologist and your primary care doctor, because there are complications later on. So I hope I answered the question. On when we get consent forms, the consent forms that are given to us are dictated by the individual hospitals. Basically, lawyers are involved in writing those consent forms. When I put my pre-op note, I try to include the major complications. And we always, always, always tell the patients and their families, if you have any questions, please ask us. Now, I'm not the only one getting a consent form on this. the anesthesiologist also, and they go through a lot of different things as well. And they also have a pre-op note as well. So it's pretty extensive. It's pretty extensive on the elective. Now, emergent, it's a different story. And let's say we've got a patient, and this has happened to me, where the aorta is blown, and you just don't have time. You just do it. And then later on talk to the family or something. Or let's say a patient is coded, and you have to go back to the operating room for something. Generally, it's a consensus of at least 2 physicians who know what they're talking about, and that's documented in the chart.
And I'm sending over the next question to you now.
Thank you.
Mm-hmm.
The next question are the statistics regarding sepsis deaths worldwide, just in the USA, or limited by some other geographic area. This becomes a very hot issue in terms of what is the diagnosis of sepsis. In the United States, we are extremely tightly controlled, and we have infectious disease people walking around all of the time, being very attentive to length of ventilator, the patients on the ventilator, how long the different IVs are in, and all of that sort of thing. Did they get prophylactic antibiotics? I think that the number quoted here is a little high for the United States. The sepsis deaths, this may be overall sepsis, but not directly related to cardiac surgery. This may be someone coming in with like what's termed urosepsis, came in to the ER with pneumonia, died of sepsis, came in with a kidney infection, died of sepsis, came in with dead gut, died of sepsis. So I think particularly in the United States, we are extremely aggressive in terms of limiting the septic deaths. And then when there is a septic death, I haven't seen a septic death in a while, but I'm in a pediatric hospital right now. So I think there's a lot of controversy whether people think it was a septic death or if it was a death due to something else. For example, pancreatitis, and you have a fever and you got a white count and all this. Pancreatitis death due to hemorrhage or something, that's not a septic death, but other people would say, well, they had this, and this, therefore it's a septic death. So I think in the U.S. we try to be very definitive regarding what we are calling a septic death. I think that worldwide septic deaths are underreported. Worldwide, the patients are not treated where in the United States we would treat them. And the quality control in the United States and in places like Canada and the United Kingdom, Australia, Europe, is much tighter than what it is in other worlds, in other countries. And I think that particularly in the U.S., we have a tendency, from the stuff I'm showing you, we report pretty much everything we can think of. And in the United States, in the hospitals, because we're so tightly controlled, there are people who read these charts who don't know what some of the verbiage is, and they'll put down this patient has an infection when in reality they don't. So there's contradictions in the charts and in terms of what the clinical impression is. A good example of that happened in Beth Israel. I was asked by one of the colleagues. It happened to be troponin was elevated in a patient who had a cabbage, and someone wandered through and said, oh, the patient had a myocardial infarction. Well, no, the muscle was cut and the troponin bumped, and the patient did fine. And the clinician was upset because it went into the database as such. And I think we have to be very careful what we're calling septic depth. United States, I think we're doing a pretty good job of getting things under control. Now, coming in with pneumonia or coming in with in full-blown sepsis, that's a completely different ballgame. I think that many of these patients end up dying. They're at an end stage many times when they're seen. And those, I think are septic deaths.
Thanks, Dr. Mahan. You can continue with the presentation.
All righty. So we'll go to the complications reported to the congenital heart surgery database. In all of these databases, we report all of the complications. We don't just say, well, we had a complication, we don't have to report anything else. We report everything. Certainly deaths and the complications, if you look here, the complications that are reported is less than or equal to 30 days of surgery. Unplanned readmissions in the pediatric population must be reported, and it's not unusual for a patient to go home and then they come back, and in our population of patients, everyone's afraid of congenital heart disease, so the safest thing to do is to admit them to the hospital. That admission, no matter what, has got to be reported. Multi-system organ failure, not that common. We do see it. It does have to be reported. Cardiac arrest or following procedures, and in these pediatric populations, with even the diagnostic caths, they can arrest. Their pathology is quite complex. So the issue with the multi-organ failure, I put this slide in to kind of show you what different organ systems are affected. And the problem is you get into this vicious cycle, and it's difficult to get out of that cycle once you're in it. Cardiac dysfunction resulting in low cardiac output, we have to report, and we have to report how we intervened. Cardiac failure, which is severe cardiac dysfunction, again, we must report. Endocarditis, infection of the heart, usually of a patch or valve. Again, pericardial effusion requiring drainage. As in the adult population, we do get effusions in these children. Now, a little bit unique to the pediatric population is something called pulmonary hypertension. We do see it in the adults with thoracic disease and with cardiac disease, but in the pediatric disease, population, it's a different type of pathology, and it's a very severe pathology, and particularly in the young children, you can get what's called a pulmonary hypertensive crisis, and they can die. And many times it's difficult to break out of that cycle. With the pulmonary hypertensive crisis, it's defined as the pulmonary artery pressure is greater than the systemic pressure. Now, this is a picture of endocarditis, and this happens to be the mitral valve. The problem with endocarditis, the mitral valve is involved, but what happens, this tissue is all close to each other, so it's not unusual for other valves to become involved, and that is problematic. And you have to decide whether you're going to need to do something surgically or if you're going to be able to treat it with antibiotics intravenously. Now, in our population, we have a lot of pathologies. The adults don't. Pulmonary vein obstruction is very common. These children have complex pathologies. It's not something you normally see in the adult population. It's seen rarely. Systemic vein obstruction, likewise, in this population, in many cases, you're dealing with children who've had multiple cardiac caths, and then we have to do something, and the vein becomes obstructed, and it's not something we can easily open, and it has to be reported. Bleeding we do see, generally with the pediatric population. Fortunately, we do not see it as frequently as we see it in the adult population. We also, in some cases, have to leave the sternum open. If we kind of know we're going to have to do that, it's called a planned procedure. There are times where we are not planning to do that, and we have to report that as well. I wanted to spend a little time on pulmonary venous obstruction, which is quite severe. People usually talk about 4 pulmonary veins draining into the left atrium, 2 from the left lung, 2 from the right lung. The thing is, many times we're doing operations where we're doing surgery around these areas for various reasons. We're doing surgery on these veins, and you can get an anastomotic stricture, but the unfortunate situation is, yes, you can get an anastomotic stricture. The unfortunate problem is many of these congenital heart disease where interventions are required on these veins, they have progressive disease of their natural veins, irrespective of if they're being operated on or not operated on. And that is not a good thing. The outcomes generally are not great. Unplanned cardiac reoperation during the postoperative or post-procedural time, exclusive of reoperation for bleeding. Say, for example, patient's cardiac output is low and you've put in a valve. It's a redo operation, and you know the coronary arteries are close to that valve. The valve is shifted, is now occluding the coronary artery, and you have to go back in and redo the valve, something along that line. Interventional cardiovascular catheterization during the postoperative or post-procedural time. Our cardiology interventionalists, fortunately, are getting very, very good. Many times when these patients are presented at the cath conference, we'll say, we're going to take care of this, and I think that you're going to have to do this. All right. Now, most of the time they're planned, but there are unplanned interventional procedures that are required during the same hospitalization. Again, the children, like the adults, can have a non-cardiac procedure during the postoperative period. And the child, our children generally, the smaller children, we cannot put in a balloon pump because of the size of the balloon pumps. We need someone who's more adult sized to be able to use that. The ventricular assist device that's been FDA approved is the Berlin Heart. We do have extracorporeal membrane oxygenation available. And many times we know if these are going to be needed before we do the operation. Arrhythmias in these patients is very common. And the unfortunate thing with the children is arrhythmias, even in simple, what we consider simple procedures, are not that uncommon. Something as simple as closure of an atrial septal defect. Using electrocardioversion or defibrillation is not common in the pediatric population, but it does occur. And arrhythmias necessitating pacemakers. Many times we, as pediatric cardiac surgeons, because we know the anatomy, we know the incidence of a particular problem, we, in some cases, will put in pacer leads and leave them there in case they're needed. And it's easier to put a generator in than to reopen a child's chest. Temporary leads, we put in all of our patients, but in terms of necessitating the pacemaker, that means in the intensive care unit, did we need to use the pacing system? And it's not unusual that we need to do that. Now, I wanted to put this slide up because This is a transvenous access for a pacing system. This works in larger patients. On our small babies, we have to put the leads on the outside of the heart. And in our real small babies, we have to put the generators, that little box on the, it would be on your left there. We have to put it in the chest cavity, and on the real small babies, sometimes you have to put it in the abdomen. And that can create complications of their own. Again, chylothorax, we see a fair amount of chylothorax. Everything is much smaller in the babies. I use 3.5 loops. We can't see these. We know where they're supposed to be. The anatomy is different in every single patient. If you see something that looks like a leak, you do everything to try to prevent a chylothorax. Sometimes you're not successful. Effusions are not that common. That require drainage. We may have some small pleural effusions that respond to diuretics. Pneumonias, again, the issue of the ventilator is very real. The longer the time patient's on the ventilator, the higher is the risk of pneumonia, and everyone tries to get the patients off the ventilators as quickly as possible. Pneumothorax, we do see. Many of them don't require drainage or evacuation, just oxygen. They reabsorb them on their own. Respiratory insufficiency requiring ventilatory support greater than 7 days. This is something certainly we try to avoid because we know the complications go straight up. Reintubation, if you have to reintubate a patient, the morbidity and mortality goes straight up. And again, you try to prevent all of that with different things. Chest PT, suctioning. The children are very good at crying, and that's a really good pulmonary toilet. At the older children, we use incentive inspirometry. We have them blow bubbles, walking, coughing, and deep breathing for the older children. And I put this picture in for the pneumonia, kind of what happens. You try to stop at every stage, and the big problem now is we're identifying pneumonias with organisms that we didn't see before. So we're getting better at doing a lot of things, but we're seeing stuff we never saw before. Tracheostomy is a disaster if it's required in the pediatric patients. There are complications. They tend to grow, and even if you're able to remove the trach down the line, they have to be followed for life because you can get a stricture. Pediatric patients who end up with a tracheostomy, that is thought about for a very long time before it's offered. Again, renal failure. We do have renal failure. It's not common to require dialysis, but certainly there's a bump in the BUN and the creatinine, and by definition, they have renal failure. We try to handle that without doing anything in terms of requiring dialysis. Many times it's just a change in medications. We have to say whether it's requiring dialysis or not requiring dialysis or hemofiltration. Sepsis, we have to report. And this is a tracheostomy in a little bit older child. Children, neurologic deficits. Many of the children and some of the adults have to undergo deep hypothermic circulatory arrest. There are neurologic deficits that may not present up front, but may be important down the line, and they are followed very closely by the cardiologist, and in many institutes, the neurologist, if required. Transient neurologic deficit, we do see this in some of the children. They'll not be able to move a leg or something, and then they can, and the etiology may not be apparent, but we have to note that when with the STS database. Paralyzed diaphragm. There are several reasons for a paralyzed diaphragm. Phrenic nerve injury is the one we're most concerned about. in the small babies, unlike adults, adults can breathe with other muscles. The small babies are diaphragmatic breathers, so it's something that's more of a problem in the pediatric population than in the adults. And some of them will require surgery to get them off the ventilator. Peripheral nerve injury, we look for those. Positioning of the patient, you'll see in the operating room, there are multiple people watching how a particular patient is positioned. We're very attentive to the different nerves and pressure neuropathies. Seizures, we believe, are being underdiagnosed. There's a lot of discussion at the national and international level how to better address this, and there's some question whether they should be on some sort of prophylactic anti-seizure medication. Now, I put this in because this happens to be for DTGA. And some of the initial studies, DTGA is transposition of the great arteries, where the aorta that is supposed to come off the left ventricle comes off the right ventricle, and the pulmonary artery that is supposed to come off the right ventricle comes off the left ventricle. The initial studies that were done on these different patients was actually done on DTGA in terms of neurologic deficits. And these patients, they were done up in Boston Children's. And the reality is that they found out that these children, people became more interested because they started identifying multiple different types of deficits that they did not know were present, and then the children were followed closely. And what has resulted from all of that is that we, particularly on the pediatric patients, we are intervening, and the hope is that the deficits are not as great as they were back in the 80s and the 90s. What has happened now with the pediatric population in particular, we're also using it in the adult deep hypothermic circ arrest. It used to be that you would cool them down to like 18 degrees centigrade, and then you drain all the blood out and do whatever you needed to do with no blood in your face and put them back on the heart-lung machine. What we're now doing is what's called antegrade cerebral perfusion, and that procedure basically means that we put a small catheter that's going to send some fluid perfusate up to the brain during the period of time where we have drained the blood from the rest of the body, so we can do the procedure that requires a bloodless field in the shortest amount of time. But we're finding that that has helped. The techniques that are being used and the perfusate that's being used are being refined, but certainly we're finding that the patients are doing better. Spinal cord injury, neurologic deficit, persisting at discharge. Spinal cord injuries in the young children are not as common as they are in the adult population. The reason for that, this is not really clear, but the spinal cord injuries, it's rare in the pediatric population. Stroke, we do see. And if we have to operate on a child who's had a bleed into the head early in their life, and now we have to operate for some congenital heart pathology, they're at increased risk to extend that stroke. Subdural bleeds, we do see, and some of these children will need them drained. Intraventricular hemorrhage greater than grade 2, we do see. Thrombus, we see that they're not that common, but they have to be reported. Now, I put this in terms of aortic cross-clamp time and risk of neurologic injury. The bottom line is the longer the cross-clamp time, the more likely you're going to have a neurologic injury. And cooling does help. So that's important, and we do use that information. It's not common to see thrombosis or thromboembolism in the pulmonary artery, but it is seen. Peripheral deep vein thrombosis in the very young child is not seen that commonly, but it is seen. We have to be attentive to that, and we have to diagnose it because they will require some form of anticoagulation. Now, one of the problems that's separate from the adult population is that we have, many of our children have what's called shunts that we create. And basically what that means is we're getting blood from the aorta to the pulmonary arteries. And one of the big problems is that shunt can thrombose. And that is a life-threatening situation in most circumstances. Those children are on some sort of anticoagulation, but it has to be recognized quickly and it has to be addressed quickly in order to save the life. Systemic artery thrombosis with the children, because the vessels are smaller, we do see, but it's not that common. And peripheral, likewise, we do see because they're smaller vessels. Usually they resolve. The young children, unlike the adults, they generally don't have the atherosclerosis that the adults have. Emboli, we likewise see most of the time it's from some sort of a clot. Vocal cord dysfunction, the recurrent laryngeal nerve injury, is something that we see with the young child. They're not as able to protect themselves from aspiration. And so we have to identify this so we can help them with their feeding difficulties. Many of these children have feeding difficulties up front as it is. Wound dehiscence, many of these children will slobber all over their wounds. We try to keep them clean. We try to keep dressings on them. But the unfortunate reality is they'll spill their milk, their food, slobber everything, and the wound will open up. It's called a sterile wound dehiscence, and that can be any location. Sternal instability is much more common in the adult population than it is in the pediatric population, and wound infections are much more common in the adult population, especially with diabetics and the deep wound infections. Yeah, we see them, but not common. Mediastinitis, very uncommon pediatric. The superficial stuff, people think just because it's a little red, it's an infection. That's not quite accurate. And there are, in our STS database, we now have to report anesthesia-related complications. And I'm going to talk about that in more depth in a little bit. The cardiovascular catheterization procedure, they have complications. A good example is something was placed in the interatrial septum, and it was a little small, and now it's not catching the tissues and is embolized into the right ventricle, and now we as surgeons have been asked to go in and fish it out. Compartment syndromes, more common in the adult population, and I'll show you a picture of that. And any other complications that we believe should be reported, to include operative and procedural complications. This is compartment syndrome. The leg on the left you can see is swollen edematous. This most likely they're going to have to open up these compartments in order to save the muscle. So we have to also tell them what the date of discharge is. We have to tell them, unlike the adult population, where the child went. Our children, many of them go to chronic care facilities. If they had some sort of a VAD, we have to discuss that. If they've had a feeding tube, nasoenteric tube, many of the children need nasal tubes. Those have complications in and of themselves. There are many of the children who require G-tubes or J-tubes for feeding. And the database discharge, many of these children we try to follow as long as we can. Now, if you readmission within 30 days, We have got to report that, and there's a multitude sort of thing. It's not uncommon for mom to bring the child in after a couple of days at home because you had all the nurses taking care of the kid. And the child's had a big operation. Oh, my baby's breathing funny. Comes into the ER, and now we have to report something like a respiratory complication, airway complication. The child may be doing okay, but the mother has identified something that's concerning to her. So on the children, we do look at the status at 30 days. We look at the status at 365 days. For our own knowledge, we're trying to get that out as far as possible. We're trying to extend our knowledge in terms of the adults also, so we have a better understanding of how these patients do as well. Now, something that's relatively new, and it's put into the congenital database, is the anesthesia adverse event. And these are pretty extensive, and anesthesia has got to report these in their own database in the electronic medical records. They put this information. Now we're just collecting this stuff. So some of this I think you saw. I mean, respiratory arrest, bleeding, stridor, extubation, endotracheal tube migration, airway injury, hemoptysis, laryngeal spasm, bronchospasm. These are things that are not that uncommon. Arrhythmias during central line placement, heart injury with central venous line placement, vascular compromise, pneumothorax from placing a line, hematoma requiring a relocation of the catheter placement, arterial puncture when you didn't want to do an arterial puncture, ischemia, bleeding, intrathecal puncture, local anesthetic toxicity, neurologic injury, anaphylaxis, which we see a fair amount of in pediatric patients, problems with medication doses. These are children are megs per kg in most cases. With the adults, usually you'll just say, give them this many milligrams. Children are different. We have got to make sure we're going by weight. Airway injury, protamine reaction, malignant hyperthermia. There's a multitude of things that with the TET babies, hypercyanotic episode, TET spell, which it's not unusual with the blue TETs, and they're putting the child to sleep. Pulmonary hypertensive crisis. Some of these children are quite sick and decompensate very quickly. Our cardiac anesthesiologists put in the transesophageal echoes, and there are complications related to that. And it can compromise the airway. We have to take it out. It can cause hemodynamic compromise. These are smaller patients. These are not large patients. It can cause the TEE. You can get extubation when you're moving this echocardiac, the transesophageal echo probe around. You can have complications during patient transfer. They can arrest. You can have peripheral nerve injury due to positioning. You can have malfunction of different equipment in taking it, especially the newborns. Many of they have paper thin skin, and just touching them or putting things like soap to clean their skin can cause problems. We're very attentive across the board. We're attentive to the eyes. Nausea, vomiting from medications. All of these are now being reported, and we're trying to adjust as needed to ensure that they're having safe anesthetic management and to capture these, what we consider adverse events. Now, INTERMACS has just recently been started, and basically we're dealing with older patients, sicker patients. We've developed equipment where we can basically save some of these children that we couldn't save in the past. But all of these devices have complications, and the complications, the adverse events, we are now requiring that they're being reported. So the basic that is ventricular assist device management. And this ventricular assist devices come in several flavors. Basically, you have left, right, or you have what's called a bived, where you assist both ventricle. Ventricular assist devices are preload dependent, EKG independent, afterload sensitive. You have to anticoagulate them. They're prone to infection, bleeding, thrombosis with associated stroke, and mechanical malfunction. So although they've saved a lot of lives, there are problems that is associated with it. So in the normal heart, you have blood coming in through the inferior vena cava, superior vena cava. It goes into the right atrium, then the right ventricle. It goes into the pulmonary artery, comes back to the left atrium, goes to the left ventricle, and out through the aorta. But if the ventricle is functioning, say your right ventricle is not functioning, what you do is you put the drainage catheter above the right ventricle at some point. It can be in the right atrium, that's common, or it can be inferior vena cava, right atrium. And then you put where you have like a little pump there, and then the blood goes from the blue blood coming from the veins, go into this little RVAD, and then it's pumped into the pulmonary arteries. And basically, you're trying to keep blood out of the right ventricle, and you're trying to let the right ventricle heal. Hopefully, that will work. Okay? So there are different types that are available. Certainly in the United States, we don't have as many as they do in Canada, United Kingdom, Australia. These are all FDA approved. The only one approved for children is the Berlin Heart. And I put this in to talk about the different profiles and how you evaluate them and what your management is for different things. So if you have, for example, let's say both the left and the right side are failing, your right ventricle generally gets blue blood coming from the veins that drain the lower body and the upper body, and elevated JVP means jugular venous pressure. And jugular venous pressure, if the right ventricle is not functioning, it won't allow the blood to drain from the upper body into the right ventricle, and the pressure will be elevated, and you'll get that vein on the side of your neck will become distended. Ascites means your belly blows up because your blood from the lower body does not drain into the inferior vena cava and doesn't go into the right ventricle. So basically, what's happened is these are the right-sided findings in right-sided in biventricular heart failure. Your left-sided findings is you'll get some shortness of breath with exertion. You can't lay flat. You'll get a widened pulse waveform. Your left ventricle will appear larger on the echocardiogram. You may have mitral regurgitation that you usually didn't have. You may have aortic insufficiency. The pressure in the left atrium and left ventricle are higher. The elevated PCWP by RHC is elevated pulmonary capillary wedge pressure by right heart cath. It's a quick and dirty way to measure the pressures in the left ventricle. So what you're looking for, your initial evaluation and management without putting in a VAD, is you look for dysfunction. I'm sorry, this is after they put a VAD in. You look for your LVAD dysfunction, thrombosis. You use vasodilators if the blood pressure is elevated, because you want to do what's called afterload reducing. You use some drugs that help the heart beat, and you diurese them. And sometimes you can speed the rate of the emptying of the VAD up as well. So when we're doing these, we have people who are technicians, physicians, of course, But technicians who are watching the patient very closely and knowing what kind of a device the patient has, and they're looking for specific signs, and they've got charts that tell them basically what to do. Now, what you're seeing here is, this is urine, and this is hemolysis, and it's one of the complications of using a ventricular assist device, and that can be a problem. And this, I'm just showing you symptoms of right-sided heart failure, where you can't pump the blood into the pulmonary arteries. With early right-sided heart failure, you just feel tired. You just don't feel good. Your heart beats faster. You feel like your heart's thumping harder. If you have backward failure, you can have backup of blood going to congestion, where your legs get all swollen, your belly gets real fat. So you get, this is ascites. This is one of the complications we dread. This is thrombosis. We do anticoagulate these patients, but unfortunately, under the best of circumstances, this does occur. It has occurred and continues to occur. Infections is one of the biggest complications of these devices, and we try to keep them out of the groins. The highest incidence of infection are those placed through the groins. The least is through the subclavian vein, but some of these patients, you're forced to put them into a place where you don't want to place them because of access problems. And this is an example of an access infection. Stroke, bleeding, it's unfortunate, but it does occur. We're constantly watching, and we try to prevent it. We try to adjust our anticoagulation as needed, but they do have complications. All of these devices have saved a lot of people, but all of them are associated with complications, and we use them. You're constantly looking at the benefit versus the risk. So it's important, especially as a clinician, as a physician, as a surgeon, every patient is different. Every situation is different. We have guidelines, we have protocols, and we have to take these into account with an individual patient and the facilities. There are multiple overseers in cardiothoracic surgery within the hospitals. Constantly, people are looking at these charts. It's not only within the ICU, they're presented at multiple conferences all the way up to the high-level quality control people. Patient with the same diagnosis, what is indicated in one particular situation may be contraindicated in another. And as a physician, do no harm. Doing nothing may be the right treatment. And just because we can do something does not mean that we should do something. I want to thank you for your time.
Thank you, Dr. Mahan. If all the attendees can enter in the passcode for today, which is cardiothoracic, and any questions that you may have. And I am sending over the first question for this section.
Thank you. Yes, and there's dietary recommendations and restrictions for all of these patients. Almost all of the teams have a dietitian/nutritionist assigned to the team. These teams are large. We have cardiologists, cardiothoracic surgeons, dietitians. We have PharmDs, intensivists, anesthesiologists, perfusionists, and all of these people are patients. Generally, these patients are known by a large team. In terms of the dietary recommendations, it depends on what the pathology is with a particular patient. To look at a patient with, for example, let's say you've got a coronary artery disease patient, keep it simple, who's a diabetic. Most of the time, our dietitian and nutrition department, they actually have handouts. They consult just like I consult. They go over everything, all the recommendations with the patient. Let's say they developed a chylothorax where you have to change what they're eating from a fat standpoint. They'll show them everything that they can eat, cannot eat. If they're on Coumadin, we have a long list of what you cannot eat when you're on Coumadin. And most of the children in particular, many of these children have what's called failure to thrive, and they're in special clinics from a dietary standpoint until they gain weight to what is acceptable. Many of these children have enzymatic and genetic abnormalities, so we have to adjust our diets based on what their needs are. The other thing we've learned with the children, whereas my generation, all we had was kind of milk, now there are so many formulas. A lot of these kids, they cannot tolerate a lot of these formulas, and we have to change the different formulas to meet the child's need.
Thank you, and I'm sending over the next question to you.
Thank you. We have never had a HIPAA problem. The information goes into the Duke database, and it is all confidential. And interestingly enough, when a lot of this transparency issue was being discussed, the Congress asked for our senior people to present and to talk about the database and how it's improving the outcomes. What is happening right now, we've had problems with Duke because they're basically, we're talking to statisticians who are not clinicians, and we're having problems communicating despite a lot of work. We're switching over to what's called a world database. And to my knowledge, the information that is inputted does not, you really cannot identify the patient from the information that's inputted.
Thank you, and I'm sending over the next question.
Thank you. The next question, are you comfortable with EMR reporting as appropriate documentation to explain activity and outcome? I'm assuming that's electronic medical records, and the answer is absolutely not. Electronic medical records it's a major problem. It's a major problem. I do a lot of quality control. I've been doing quality control since 1983. And the unfortunate scenario, you got a lot of people who absolutely love these things, basically because they think they're getting a second-to-second or minute-by-minute documentation. But the reality is, when you start looking at these charts, people are copying and pasting. They're very inaccurate in terms of what their statements are. When you go back and see how the nurses have put in the timing and when medications were given, there are a lot of mistakes, and I don't care which electronic medical records you're using. I've used the VA systems. I've used the ones up at Harvard. I'm using the ones we've got down here. We got to get back to common sense, and people depending on these electronic medical records as being the statement, the documentation, the accurate. It's false. It's false. And even with our patients, where we're with pediatric population, you'll see the documentation tends to be a bit longer because we're dealing with children with a lot of problems. And even here, if you start going from one progress note to another, you'll see discrepancies very, very quickly.
Thank you for answering that, and I'm sending over the next question to you.
Thank you. The most preventable complications arise as a result of doctor errors, nurse errors, CNA errors, tech errors, or lack of sanitation or other errors. I mean, as I said, this is a team approach. And my general impression right now, as a clinician who basically started back in the 1980s, is that people have become much too dependent on what you would consider a team approach and not taking ownership, if you will, of the patient. So that what will happen, for example, is a common theme is that I operate on the patient in the operating room. We write orders. You move them to the ICU. Quote, it is my patient. The intensivists say, it is my patient. You cannot write orders. And the people who are inputting orders are residents and fellows who are junior, who have not seen enough to understand what the different issues are or what the more subtle clues are to problems. So I think the team approach, the large team approach, has created a situation where I think that the so-called preventable complications are happening because there are just too many people involved. The nursing staff are in a very difficult situation because they have quality, they got their senior nurse in saying they have to fill out all these documents. There's way too much time spent on the paperwork rather than taking care of the patient. And I mean, even our residents and fellows, you have to corral them. They're in looking at all of the electronic medical records and, oh, well, this happened. I said, have you looked at the patient? And, you know, I think that you have to get back down to basic medicine, and that means that forget about the paperwork. Yes, it's important, but you have to remember your doctor, your nurse anesthetist, your tech, you are taking care of a human being in front of you. And I think that what's going to have to happen is that the documentation has got to be more precise, and you've got to stop. If you look at some of the stupid H&Ps, I mean, they're completely worthless. Notes from some of these people, I'm having to review for morbidities and mortalities, and I can't find the information I'm looking for. And I mean, I'm very good, I've done this for years. If I can't find it, other people can't find it and don't know where to look for it. So I think the preventable complications are basically occurring because the team is just too large, and there is not someone who is allowed to be the person who makes the final call.
Thank you. And I am sending over the next question to you.
Thank you. The cardiologist, there are things that the cardiologist do. There are things that an anesthesiologist does. There are things that I do as a cardiothoracic surgeon. Each one of us is responsible for our field. There is certainly a large overlap, and certainly when I talk to the patients and their families, I'll say the anesthesiologist will put you to sleep, we'll put a breathing tube in, we'll put a line in the artery, we'll put a line in the neck. And I'll go through some of that, and I said, you will be seeing the cardiac anesthesiologist. Likewise, when I am standing by for a cardiologist and I meet the families, I'll say, the cardiologist is doing this, I want you to know we've been asked to stand by and we're not anticipating anything, but the cardiologist is thinking of this, and if this is a concern and we decide as a team that we need to do the next thing, this is what we're going to do. So each one of us is responsible to talk to the patient and to get a signed consent for whatever, like with me doing the operation, let's say I'm doing a closure of a ventricular septal defect, I do not get consent for the anesthesia portion of that. I get consent for the ventricular septal defect closure. And usually the anesthesiologist, there's a big problem going on right now between anesthesiologists and cardiologists because there are credentialing anesthesiologists doing cardiac anesthesia. Many of them can do cardiac echoes. They've been credentialed. So if they've been credentialed, yes, they get that. But if they see something and they're not sure about, usually a cardiologist is around to help out. But if someone is credentialed to do it and they find something intraoperatively that they weren't expecting, and then they consult the cardiologist is not in a position to get a consent. He's a consultant to the anesthesiologist at that point.
Thank you. And I'm sending over the next question.
Thank you.
Mm-hmm.
In a prior bypass graft patient, are there specific risks of complications in the second heart surgery, such as a valve replacement? How reliable is the STS score? Yes. There are specific risks of complications in someone who's had a median sternotomy in the past. And one of the problems with doing a redo median sternotomy is that some of the grafts can float up, the heart can float up, you can get into the heart, you can get into the grafts, you can get into the aorta, you can get into a multitude of things. Just because I've had hearts that have basically become part of the posterior table of the heart. And that is a serious problem. So when I talk to patients who've had prior surgeries, and when you're talking peds, you're talking many of these kids will have 4, 5, 6, 7, 8 surgeries in their lifetimes. So it goes up, the complications go up, and the surgery becomes harder, and many times you can't identify, it's very difficult to identify structures. How reliable is the STS score? In my opinion, it's not that reliable. I mean, we're required to, with the adult side on the risk calculator, many of the insurance companies are requiring a thing. I review charts on this, and I can tell you I calculate it based on the information I'm given, and inevitably it's a different number than what was recorded in the chart. So I don't think the STS score, the online risk calculator, is that accurate. What is important is what the Society of Thoracic Surgeons have done is that people in different fields have looked at different populations, at large populations, and have come up with mortalities and different morbidity scores. And I think that's more reliable than the STS score. So if someone asks me, for example, my child is going to have an atrial septal defect closure, I can tell you internationally that the chance of dying for that child is less than 1%. So, you know, I'm having a redo chance of dying. If you look at the Society of Thoracic Surgeons, pediatric population chance of dying is 20%. So when I give them numbers, I'm very specific as to what the information, where the information is from. Usually with the pediatric side, it's like the numbers I'm quoting is from the national level, which also involves international organizations. And this is the number that's quoted.
Thanks. And our last question that we have time to answer, I'm sending that over to you now.
Thank you.
Mm-hmm.
That's an ethical question. Can you perform complex surgeries on people who are quarantined, for example, because of coronavirus? I, as a cardiac surgeon, would not hesitate. That's an individual decision. I've been in those situations, not as bad as this, but I think that you as a clinician have to make a decision, and it's very much an individual decision. And, you know, you have to understand that you can, as a clinician, you can die, and you have to know that.
Thanks, Dr. Mahan, for answering those questions. Please remember that if you are applying for CLE credit, you must have attended for the full 120 minutes of this presentation. You are also required to complete the survey at the end of the program. Please note you will be receiving your certificates via email in 24 to 48 hours after the presentation. I want to take this opportunity to thank everyone for attending, and most especially Dr. Vicki Mahan for her time and effort in creating this presentation. If you would like to speak with Dr. Mahan, or if you would like to speak with a TASA representative, please contact TASA at 1-800-523-2319. One of my colleagues will be following up with you regarding your feedback on today's presentation. Again, thank you all for attending. This concludes our program for today.